This is a patient, 11 years old. She has a Chiari. She's had a prior Chiari decompression. She has a syrinx in her thoracic cord, and she gets imaged every couple of years to take a look at that syrinx, make sure everything is doing fine. She doesn't do very well with holding still, so she typically ends up getting anesthesia, and to image the entire spine with anesthesia can take well over an hour of scan time, and certainly more than that of time in the room. And these are, I think, a way that we may get away from that. So these are 3D acquisitions. These are both sagittal T1 and sagittal T2 images acquired only in the sagittal plane, and that's the extent of the exam in this patient. We didn't acquire any axial images. We're able to do that because we can do these really fantastic axial reconstructions from those 3D sequences, which eliminates the need to do multiple acquisitions in the axial plane. Because it's 3D, you can angle them any way you want, and this gives us a great look at the syrinx in this patient. I think you can very easily measure this, be very confident that it hasn't changed since the prior study. You get a nice look at the signal in the surrounding cord. You can even see the adjacent nerve roots. I'll show you another example of that in just a few minutes. But there's a substantial time savings here. And in an 11-year-old, this actually is getting us to the point where we don't need anesthesia. We're able to do these patients much faster, and a lot of patients are able to get through. Here's another example of a 7-year-old. This is a patient who has medulloblastoma, and as you know, these patients get imaged frequently looking for new metastatic disease in the fecal sac. I'm going to actually scroll through the source images here so that you can get a sense for how useful this can be. These are the T1 post images, the 3Ds, and here, awesome arrow. As we scroll through, you can start to see, we get into the fecal sac here, you start to see the nerve roots coming down from the level of the conus. And as we get towards the midline image, right about here, I think you can very clearly see this is the distal fecal sac, and there's nothing there. There are no drop mets. There's no abnormal enhancement along the conus, along the arachnoid here. And so I feel like I can be very confident with these 3D images that there are no new metastases. They're much thinner, and I think they're very sensitive to the presence of abnormal enhancement. You can see the fat saturation is beautiful here, but this is a young, small patient, so we get really nice imaging with this sequence as we come through all the way to the end of the other side. You can very clearly see those nerve roots of the cauda equina coming down. Really nice visualization. If there was something there enhancing along those, we would see them really well. And I feel more confident now reading these as 3Ds than I did with the 2Ds, including the axial acquisition. So I think it's a win-win for everyone. So what's the big deal? That patient was done in 20 minutes. You're talking about just sagittal acquisitions and then axial reformats. You can get them in any plane you want. You can oblique them. You can get them parallel to the disc if you want. It certainly reduces anesthesia time in patients that need anesthesia. In a lot of cases, we're able to avoid anesthesia, and there's certainly a lot of push to do that. A lot of literature coming out now that maybe in the developing brain, multiple exposures to anesthetic agents is not the best thing. And then from a practical perspective, you can increase your throughput. You can reduce the slots you have to allocate to these patients. And the patients are happy. They don't have to spend as long lying in the magnet. So it's really a win-win for everyone. These are our actual protocol numbers. This is literally what we started with and what we do now as far as how long it takes us to image these patients. And as you can see, it hovers around a 40% time savings by doing these 3D acquisitions. So what I think is sort of the next thing, and I'm always pushing Frank on this a little bit, is I really think that what we should be doing is trying to push this technology out to adults. Obviously, we don't do a lot of pediatric spine. Nobody does unless you're at a children's hospital. We have these patients 1 or 2 a week where we might do a total spine. But we do a ton of adult lumbar spines and cervical spines. Every day we're doing 20, 30 of these exams. If you could find a way to apply this to adults and no longer have to acquire axial imaging, now you're talking about significant time savings for a big percentage of the patients you have coming through your department. And I think it works. I think we're there. I think this sequence is able to do that. When you look at these axial reconstructions, I am perfectly comfortable reading this. I feel like I have a better look at the nerve roots than I did with the old sequence. When there are small discs, small things hanging out in the subarticular regions, very easy to see with these 3D reconstructions. And this is not some idealized patient. This is more of your standard American patient. They're pretty good sized. They've got a lot of degenerative disc disease, and yet we're able to really nicely reconstruct these images into axial views. I see a question coming through. Question on reading. Where do you use the MPR tools? So with the 3Ds, because these are isotropically acquired, we can reconstruct these in any plane relative to the disc. So if we just do a straight axillary reconstruction, this patient has a pretty straight spine, but in patients who have an exaggerated lordosis, we can actually reconstruct them in planes parallel to the disc space, and that is helpful for using the MPR tools that are available. Or certainly we can even do obliques in the cervical spine. Our neurosurgeons, for years, we've acquired cervical oblique images through the neural foramina. So that actually means we're usually acquiring 2 additional sequences in the cervical spine when we do our conventional imaging. If we do 3Ds, and we're working on this right now to really get it optimized, we don't have to acquire those anymore either. We can simply reconstruct in those oblique planes and not have to, and we can save another 10 minutes there on every cervical spine that we do. So the ability to do MPRs and reformatted images is really huge in 3D.
Innovation and you. Philips.